Issues Facing Providers web conference. Today's conference is being recorded. At this time, I would like to turn the conference over to Rick Reifenbark. Please go ahead, sir.
Thank you very much. I'd like to welcome you to our latest installment of our Health Information Technology series. This program, entitled EHRs in 2013, A Holistic View of Issues Facing Providers, will cover various issues involving EHRs, electronic health record systems, from fraud and abuse to meaningful use and health information exchanges to contracting issues. My name is Rick Reifenbark. I'm a healthcare partner in the Los Angeles office of Foley and Lardner, where I specialize in healthcare compliance and transactions. My co-speakers today are Ralph Oyaga, Associate Counsel of High Tech LA, the federally designated Regional Extension Center for Los Angeles County. I've had the pleasure of working with Ralph on many Medicare and Medicaid meaningful use incentive program issues. Also, Jim Clevis, a partner in the Los Angeles office of Foley, who is also the chair of the firm's information technology and outsourcing practice. Jim has over 20 years of experience negotiating healthcare technology contracts. And lastly, Adria Warren, who's a senior counsel in the Boston office of Foley, where she specializes in healthcare transactions. She's also a member of the healthcare and emerging technology teams at Foley. Before we start, I just wanted to note a couple of housekeeping items. Today's program will run for 1 hour, and we will apply for 1 general CLE credit. Any New York, New Jersey, and Kansas attendees applying for CLE credit must fill out an attorney affirmation form and write down the course code that will be given later during today's web conference. A form and today's slides can be obtained in the materials section on your screen. And questions can be submitted during the web conference by entering them in the Q&A box. So in the first portion of the webinar, we're going to cover recent developments in fraud and abuse guidance regarding donations of EHR systems, which is a key method by which physician practices and other healthcare providers receive EHR technology. And on that topic, we're going to cover the recently issued proposed Stark and Anti-Kickback statute safe harbors regarding EHR donations, state law limitations on EHR donations, which are becoming more of a factor, and also 2 recent OIG Advisory Opinions involving EHR donations. But first, I thought we'd start with a refresher on the Stark and Anti-Kickback statute EHR donation regulations, which were adopted back in 2006. And at the time, the stated policy was that to advance the national policy of promoting the widespread adoption of health information technology to improve patient safety, quality of care, and efficiency in the delivery of health care. At a general level, these regulations permit donations of EHR software and services to certain types of recipients. However, the donations cannot include hardware and cannot involve transfers of cash. Now, the regulations include many different requirements, and I've included some of them here on this slide, but not all of them, so you'd have to consult the regulations for each of the requirements. But the EHR must be interoperable and have an e-prescribing capability. And EHR is considered to be deemed interoperable if a certifying body recognized by Health and Human Services has certified the technology no more than 12 months prior to being donated to a physician or other recipient. The interoperability is viewed as an important requirement because it limits the ability of a donating entity to lock in referrals with that recipient, so that's very important. Similarly, the donating entity can't take any action to limit the compatibility or interoperability of the EHR system. Another important requirement is that there's a cost-sharing component to the regulations by a physician or other recipient, and the recipient must pay at least 15% of the total cost of the technology that's being donated or subsidized. Must be paid before receipt of the technology, and the donating entity cannot loan the funds to the physician or physician practice. So it really has to be an out-of-pocket expense paid by the recipients. Like most Stark and Anti-Kickback statute exceptions and safe harbors, the arrangement has to be documented in a written agreement signed by the parties. And if physicians or other recipients' eligibility for the donation cannot directly take into account referrals, and the regulations specify certain criteria, certain selection criteria that will be deemed to not directly take into account referrals. The physician can't have a equivalent EHR, meaning you can't subsidize or donate a system for someone who already has a similar system. And lastly, and perhaps most importantly, these regulations are currently scheduled to sunset or expire at the end of this year. And so donating entities and physicians or other recipients that have an ongoing relationship regarding EHR where they've structured the arrangement to fit within these regulations, if they sunset, will need to have to restructure the arrangement to comply with another Stark or kickback statute exception or safe harbor. Now, the rationale for the sunset was that OIG and CMS thought that the need for protections of donations of EHR items and services would substantially diminish over time as the use of technology became a standard and accepted part of a medical practice. So remember that these regulations were passed back in 2006, and so they thought by 2013 it would have been the case that most physician practices already have the technology, so there wouldn't be a need to continue the subsidy. So as time was running out on the EHR regulations, CMS and OIG just very recently proposed an extension to these regulations. The proposed regulations came out on April 10th of this year. And they noted that while the industry has made great progress, use of such technology has not been universally adopted nationwide, and continued EHR adoption remains an important departmental goal. So, and although these proposed regulations are not yet final, this was a very welcome news for donating entities and recipients of the EHR donations who would have otherwise had to restructure their arrangements at the end of this year. So the proposed regs do three things. They propose to extend the sunset until December 31st, 2016, so by 3 more years. And the significance of that date is it's the last year to qualify for Medicare incentive payments under the Meaningful Use Program. It's also the last year to start to qualify for the Medicaid incentive payments under the Medicaid Meaningful Use Program. So what you're seeing in the EHR donation regulations is an attempt to start to harmonize them with the Meaningful Use Program that Ralph is going to talk about later in the presentation. The proposed regulations also provide that, that interoperability will be determined by a certifying body recognized by the Office of the National Coordinator, which is another attempt to harmonize it with the Meaningful Use rules, because as you'll learn, the EHR under the Meaningful Use Program has to be certified by the ONC. And also, to satisfy the EHR donation regulations, the technology must be certified within 2 years of donation, as opposed to the current regulations, which specify it must be within 12 months of the donation. And then lastly, the proposed rules propose to eliminate the e-prescribing requirement, so the requirement that the technology have an e-prescribing component. And that was because OIG and CMS viewed it as no longer necessary. They feel that there's already, providers are already sufficiently incentivized by the e-prescribing incentive program and also the Meaningful Use incentive programs. OIG and CMS also solicited comments on a few different topics, such as should donating entities be limited to certain types of entities, such as hospitals and group practices and prescription drug plans. And they hint that they're concerned about certain other types of ancillary providers that may be offering these donations as a means to lock in referrals. They also ask for comments on any other potential conditions or requirements that would serve to reduce the locking in of referrals while continuing to facilitate the free exchange of data. And also whether there should be additional specificity regarding what types of technology is covered by the EHR donation regulations. And that's a question that comes up pretty often, is what's in and what's out in terms of what can be subsidized. So I just wanted to note that if you'd like to comment on these regulations, there's still time. The comments are due to CMS and OIG by June 10th. Now I wanted to, on this next slide, note that even though that there are the federal anti-kickback statute and Stark regulations that permit donations of EHR, you need to check your state laws as well. The original Stark and anti-kickback statute regulations were very clear that they do not preempt state Stark laws or state anti-kickback statute laws. And several states, in fact, have limited EHR donations, and we've included several of the states on this slide. And with respect to each of these states, you need to carefully review what the guidance is and what the laws are. And in many cases, it's an Attorney General opinion that was issued or a Department of Health opinion. And in some cases, they limit donations by certain types of entities, such as clinical labs. And in other cases, it's a little bit more of a broader prohibition where it appears that potentially additional entities would be prohibited from donating as well. Okay. Now, in the context of donations, I also wanted to highlight two OIG Advisory Opinions, Office of Inspector General Opinions, that were released at the end of last year. The first is OIG Advisory Opinion 12-19, which involved proposed arrangements by a pharmacy to provide software to community homes that house individuals with intellectual and developmental disabilities. And there are a number of different proposals that were at issue in this opinion, but I just wanted to highlight the two that were relevant to our discussion. The first proposal was that the pharmacy wanted to sell a discounted software package to any community home that was interested in that technology. So it'd be offered to all community homes, regardless of whether those homes had any residents that were actually buying their drugs from the particular pharmacy. And the software package was discounted, but it wasn't discounted below the fair market value. So it was at the low end of fair market value, but it was not below fair market value. And then the second proposal was that the pharmacy wanted to just donate or give away for free that same software to those community homes whose residents actually use the pharmacy. So there's a more narrow universe of community homes that would receive the technology, and the technology would be given away for free. So OIG analyzed both the proposals and noted that the particular software that was at issue was not interoperable in this case, so it fell outside of the anti-kickback statute safe harbor, which meant that it was then a facts and circumstances test as to whether or not it violated the anti-kickback statute. And the OIG approved the first proposal in which the community home was in which the pharmacy was selling the software to the community home at a discount. It noted as a safeguard that the discount applied to all community homes, so there was not an attempt to single out those homes that only had customers or patients of the pharmacy. And OIG also noted that even though it was discounted, it was still fair market value, so it approved that arrangement. The OIG did not approve the free software to community homes, so proposal number 2, and it for the following reasons. It held that the software had clear independent value to the community home, so it was clearly something of value that they were getting for free. It would give the pharmacy an unfair advantage over competitors, and also it noted that the lack of interoperability means that there would be data lock-in and therefore referral lock-in. And this concern is similar to the concerns that OIG had expressed in its proposed EHR donation regulations. So I think that the takeaways for this opinion are that in the context of a donation, if you're outside of the EHR donation safe harbor, you're into a traditional anti-kickback statute analysis where it depends on the facts and the circumstances, and things like whether it's fair market value and the selection criteria used for the donation will become very important to the analysis. Okay, the next OIG advisory opinion I wanted to review also involved a proposal of free technology. And here it was a hospital that proposed to provide free access to an electronic interface to physicians. And it would also include certain support services for that interface. And the interface, the purpose of it was to facilitate the transmittal of orders for laboratory diagnostic services between the hospital and the physicians. However, the physicians would still be responsible for maintaining all aspects of their own EHR system, The hospital is only going to provide support services for the interface, not for the physician's EHR system in their practice. And the sole purpose of the interface was just to transfer test results back and forth. It didn't have any other functionality. And here, so unlike the free donation that we reviewed in the prior OIG advisory opinion, here the OIG concluded that because the interface really had no independent value to the physicians, it was just a method to transfer the test results back and forth. It was sufficiently related to the hospital's services that it did not constitute remuneration under the kickback statute. So there was nothing, it didn't view there being value that was being exchanged back and forth such that you would have a concern about influencing referrals. And this is also consistent with a CMS Stark advisory opinion on point, which also held that these types of interfaces can sometimes be okay to just give away because they didn't have independent value. So I think the takeaway here is that to make sure in the context of an EHR donation or a donation of software or other technology that you evaluate whether you have an argument that that particular technology does not constitute remuneration, and perhaps you're not even into an analysis of whether or not you have to comply with the EHR donation regulations. So now once a provider has access to an EHR system, whether through a donation program or otherwise, it can potentially qualify for meaningful use payments under the meaningful use programs. And so for more on that, I'm going to turn it over now to Ralph for a discussion of the meaningful use programs.
Great. Thank you, Rick. Let me start with the concept of the triple aim. The concept is simple. It's in order to improve the U.S. healthcare system, it requires us to simultaneously pursue these three aims: improving the experience of care of the individual, improving the health of populations, and reducing the per capita cost of healthcare. And these aims are interrelated and require a balancing act of policy and practice. For example, we know now that the first effect of enabling hospitals to utilize EHRs to better document their activities resulted in increased billings to the Medicare program. Thus, the per capita cost of care, at least in the present, has increased. We saw the knee-jerk reaction from CMS in a letter to the hospitals stating that basically that HHS has suspected fraud. But supporters of EHRs and other health information technology believe that the long-term effect in the reduction of wasteful, unnecessary, and even dangerous procedures will far outweigh the initial rise in cost. So the EHR incentive program was born before the passage of the Affordable Care Act. However, it is now seen as a driver for reform, at least in terms of the adoption of technologies that will advance the aims of the Act, such that of coordination of care. It is a carrot and stick approach. The carrot, of course, is money, the incentive payments that eligible providers will gain if they implement and utilize the certified electronic health record in a manner that the government has deemed as meaningful use, as Rick mentioned. The stick comes in the form of penalties on the Medicare side that are going to be implemented starting in 2015. And I want to note that the penalties start day one, January 1st of 2015, which means that CMS is going to be taking a look at the data during 2014. But they have to retroactively look at data. That means that you have to be, in order to avoid penalties in 2015, you have to be a meaningful user in 2013. I hope that makes sense, but it's something that people don't really think about when they're thinking about 2015 penalties. The program has two tracks, Medicare Medicaid. To be eligible, providers must demonstrate that at least 30% of the patients are in one of the two programs, Medicare or Medicaid. There is an exception for pediatricians. They can come in at a lower threshold, 20%, which is 2/3 of everybody else's threshold, which means also that their incentive payment will also be 2/3. So it's a reduced payment. Hospitals can participate in both tracks, but providers must choose one or the other. There are various differences between the Medicare and Medicaid programs, and I just want to give you a few highlights. Starting with launch dates, while the Medicare program launched in January 2011, some states didn't launch until a year later. So there's always been this disconnect between the two programs' starting points and ending points. The payment differences also, there's a $44,000 total, up to $44,000 total incentive for the Medicare program. That is based on a percentage of Part B billings. The first year payment is $18,000, up to $18,000. The way it's calculated on the Part B billings for the entire year. That means that you don't get the incentive payment until basically, your billings have gone in March of the. They allow a period for the billings to come in through the first quarter of the year after your meaningful use attestation, and then they calculate the payments, and you get your payment sometime, a couple months later, 6 to 8 weeks. With the Medicaid program, it is entirely different. It is a payment, $63,000, $750. That it's not the first year is a larger payment, $21,250, and it is not based on billings. It is just the first year. All you have to do is attest to AIU, which is adopt, implement, or upgrade to a certified EHR. So as long as you have a contract and providers have access to certified EHR technology, then you can attest and receive the first year payment under the Medicaid program. There's also other differences such as the tail periods, which is the tail periods are the deadlines for registration and attestation for the previous year. So they vary per program. Medicare has February 29th is the deadline. For Medicaid, it varies by state. In the case of California, our Medi-Cal program, which is the Medicaid, our California's version of Medicaid, the Medi-Cal EHR incentive program has had a couple of different extensions this year alone because of the state level registry portal issues. So every state is going to be unique. Also, Medicaid providers can skip years without any penalty. In the Medicare program, if you can skip a year, or you may not have the threshold that qualify you for a year's payment, and what happens is the program penalizes you by you lose that payment year. In the Medicaid program, you can skip years and just start where you left off the year after. So the one thing that I wanted to mention too, there are differences in the initiation of, so there's with the Medicare program, the last year you can receive payment is 2016. The last year that you can initiate the program is 2014. Now that would mean, of course, that you would be losing a couple of years if you start late, but you could still start through 2014. But the last year that you can receive payment is 2016. Whereas in the the Medicaid program, the last year to receive payment is 2021. So it gives providers a little bit of a sense, if you're on the Medicaid program, that you can sort of take your time a little bit more in achieving meaningful use. So there's another, that's another disconnect that we have seen in the market, whereas Medicare providers are a little more have a little more incentive to get to meaningful use and achieve the measurements right away. The Medicaid providers are not in such a rush. If any of you followed the UK's attempt at an EHR incentive program, you'll know that the biggest criticism for that program and ultimately their failure was that providers felt that they had no input or control over the program. In the United States, we have taken the opposite approach. Providers are active stakeholders in the design and implementation of the program. CMS does put a lot of effort in addressing concerns. So in the U.S., providers are at the center of the program. The measurements are individual to each provider's performance, and the providers are the ones who sign the attestation and receive the payment. So with that in mind, groups and clinics need to put the payment reassignment issue right at the top of their to-do list when they decide to participate in the program. The provider can choose to reassign their EHR incentive payment to an employer or entity with which the provider has a contractual relationship, allowing the employer or entity to bill and receive payment for the EP's covered professional services. For Medicaid providers, they may also have the option to reassign to an adoption promoting entity, but this is defined within each state's Medicaid HIT plan. Keep in mind that the provider can only assign the payment to one tax ID. They can't split the payment. They can't, take half and give the other half to another to their employer or billing entity. They have to choose. There are, this is an issue that comes up a lot with providers that are employed at different clinics. They may work at the county clinic 2 or 3 days a week. They work at a community clinic the other days, and so there's this tug of war as to who's going to get that payment. So it's a conversation that must be had, and the earlier that you start the conversation, the discussions, the better. Other registration and attestation issues to be aware of. First, remember that attestation requires a wet signature from the eligible provider. This is an annual process. People underestimate the amount of time and effort it takes to collect the wet signatures. Take into account providers that will be on vacation, part-timers, and even overbooked providers that will simply not have the signing of this document as their top priority. And also create a process for securing the document once signed, as it will be, you'll need to keep it as well as other related documentation. They need to be kept for audit purposes for 6 years post-attestation. So the registration at the national level registry, the NLR, which is the CMS registration, is required for all providers, regardless of which track they're going to participate in. So this means that if the practice is going to be using a proxy or a staff that will act on behalf of the eligible provider for purposes of registration, you need to account for, there's a 2-step process prior to entering the NLR. Number one, you have to set up the proxy account in the INA system. So the INA is the Identity and Access System. It's actually, for purposes of this EHR incentive program, it is managed by NPPES, which is the entity that assigns the NPI numbers to providers. Second thing is the proxy has to request and wait for approval from the provider to be a proxy that for that provider to act on their behalf. And in some cases, the providers don't even recall their ID and password. So then they're forced to call NPPES and get their account access reset. So that, again, is time that you need to account for. On the Medicare side, there may be provider enrollment issues, so you have to deal with PICOs. And again, it is just a time-intensive process to make these corrections. At the state level registry, there is yet another layer of management of the ticket numbers, tracking whatever problems you encounter in the registration and attestation process, and all of those things need to be resolved and managed so that you don't so you can avoid the missing the deadlines. Now, with the incentive, as the EHR incentive program progresses, we're traveling now through stage one, from stage 1 to stage 2. We are seeing, the beginnings, the setup for stage 3. There's talk about, stage 4 and 5 in the future. So as the incentive program progresses and providers move to the next stages, then the utility and the impact of EHRs will also shift. Stage 1 was aimed at getting providers to implement a certified EHR and begin to capture structured data. There's a requirement to select a few clinical quality measures, they call them CQMs, but there are no thresholds required in CQMs. So even if a provider reports 0 for the denominator and numerator, they will still get credit for those measures. This may give providers a false sense that they don't have to really pay attention to CQMs until later, but that is not the case. Stage 1, with the lower thresholds, is actually the time to take advantage of that time and familiarize yourself with CQMs and understand the rationale for each CQM and what the workflow is to capture the data elements required for each CQM within the EHR. This is where providers get to make meaningful use of meaningful use, hence the MU squared title on this slide. Albert Einstein once said, information does not equal knowledge. In the case of EHR, the EHR is simply capturing structured data or information. The provider must take that information and transform it into something useful, something that can help improve the care of a particular patient, something that can help understand and positively impact the health of a particular segment of the population, of the patient population. And yes, of course, we can't leave out, that ultimately we can help reduce the cost of care. I think that's the underlying goal of all of this. So what's next? The first phase of the EHR incentive program is ending. This was the seed money to establish a base for EHR implementations. The regional extension centers, which provided technical assistance, subsidized technical assistance to a segment of primary care providers called the priority primary care providers, will be winding down. EHR vendors will need to conform to 2014 ONC certification requirements. So this will sort of change the landscape for certified EHRs as well. Briefly, just want to mention that the 2014 edition of EHRs are going to be in the form of a basic EHR, and then there will be modules that can be added to add features and functions that pertain to your particular practice, and this will help specialists in that they don't have to necessarily purchase a complete EHR that they will only use 50% and health information exchange a standard practice. And with that, I'd like to turn the presentation over to Adria for a look at HIEs. Adria?
Thank you, Ralph. And my goal in the next 10 minutes or so is to leave you hopefully with an understanding of what Health Information Exchange is, HIEs, and why you should care, and hopefully leave you with a few practical tips that you might use as you approach some of these EHR and HIE issues that we're all dealing with right now. The definition that I've put up here is the electronic movement of health-related information among organizations according to nationally recognized standards, and that's as an HIE. And so basically an HIE relates to the movement of information and how providers and patients can appropriately access and securely share clinical information electronically. It's not the electronic storage of records. For all of the reasons that Ralph and Rick were going through, EHR adoption has been increasing, and I think CMS statistics show that physicians have increased their EHR adoption by over 80% between 2009 and 2012. However, the challenge for HIEs is linking those EHRs and permitting them to transmit information within a state, ultimately across state lines, and that's a challenge for policy, regulatory, and technology reasons. There's not a single vision or solution for linking the systems right now. States received, back in 2010, states received funding authorized by the HITECH Act and the Affordable Care Act to start to develop HIE resources and facilitate this exchange of information, ultimately with a goal towards encouraging and supporting the information across states. This is a map of where states are, these self-reported HIEs in states. With that grant money from 2010, states have taken different approaches. Some have taken a top-down approach and invested heavily in infrastructure kind of at the state level. Some have implemented local grant programs, like Texas did this, I think, to encourage providers to create smaller HIEs. Other states, like Wisconsin, are focusing on linking regional HIEs into larger and larger systems until a state's fully covered by a web of exchanges. The current consensus strategy contemplates that health systems and other providers will ultimately be able to connect directly or through state or regional health information exchanges. And in many states, and for many of us, hospital-centered HIE hubs are emerging faster than the regional HIEs are. And the question of how to relate the current hospital-centered HIEs to the hospital kind of independent statewide or regional models is being worked out as we speak. So these are some of the drivers behind HIE. I already mentioned the Affordable Care Act and HITECH, which introduced some of these new delivery and payment models like ACOs and bundled payments and medical homes to try and encourage and facilitate greater coordination of care and improved quality. Out of that, we had seed grant money in 2010 to start to develop some of the models for HIE, and the technical standards for certified electronic health record technology, as already discussed by Rick and Ralph, to try and have a uniform certification process and standard that eligible professionals and hospitals must use to meet the meaningful use criteria. Something that you should also be mindful of as you learn about these issues is what your state law requires. Some states, like Massachusetts, has implemented a law that requires providers to connect ultimately to the statewide HIE by 2017. And other states, like Minnesota, have a process in place for certifying HIE. So if you're choosing an HIE to join, then you would want to make sure that it is certified if that is what your state requires. And there might be more to come. And very recently, the Department of Health and Human Services issued a request for information. They were looking for input on a series of potential policy and programmatic changes to accelerate electronic health information across providers and exchange of information across providers. And they mentioned here that some of the future programs that might evolve might include a greater emphasis on HIE as either a requirement for participation, and that's what I would emphasize there, something that might be required for Medicare Medicaid participation. This is a high-level overview of the meaningful use stages that Ralph also mentioned. You can see in stage 2 right at the top here, and this was put out by CMS, so HIE is right there at the top of stage 2. And it also will continue to evolve and be more emphasized in stage 3 We're down towards the bottom. You have access to comprehensive patient data through patient-centered HIE. And so some of the criteria, the requirements in Stage 2 that are encouraging the implementation of HIE are illustrated on the next few slides here. The first is summary of care records, and these are core objectives. So Stage 2 is structured very much like Stage 1, where there are 17 core objectives to be satisfied, and then there's a menu selection of 6, of which you would choose 3. And these ones are core objectives. The summary of care records, it applies to, for transition of care, having a provider provide a summary of care record for more than 50% of its transitions of care and referrals. And this criteria does not specifically require electronic transmission, but it's an element, obviously, where electronic transmission may come into play. The next few do expressly address EHR and electronic exchange of information. Transitions of care will require that 10% of transitions and referrals, the hospital or eligible provider that transitions a patient to another setting of care must provide a summary of care record either EHR to EHR or through an HIE. So having an HIE that complies with kind of the national framework of standards. The third requirement is electronic exchange. Hospitals and eligible providers must either conduct one or more successful electronic exchanges with a different EHR system. So if your practice uses Epic to relay clinical information to a user or Cerner, or conduct one or more successful tests with a CMS-designated test EHR during the measuring period. And so this criteria is obviously designed to ensure that a provider's EHR is able to transfer summary of care documents directly to another provider with different EHR. Transmission of prescriptions, again, this is one of the required or core meaningful use requirements. More than 50% of all permissible prescriptions written by the eligible provider must be compared to at least one drug formulary and transmitted electronically using EHR. This was also in Stage 1, but it's a higher threshold. I think it's gone from 40% to 50%. And for hospitals, there is an optional Stage 2 meaningful use requirement with more than 10% of the hospital discharge medication orders for permissible prescriptions are compared to at least one drug formulary and transmitted electronically using EHR. And in addition, that hospital labs must send structured electronic clinical lab results to the ordering provider for more than 20% of electronic lab orders received. And commentary suggests that either an HIE or a separate system-to-system interface may work to satisfy this criteria. Some of the buzzwords that you've heard throughout our talk: the Office of the National Coordinator for Health Information, or ONC, that was the entity that was charged with building this interoperable, private, secure, nationwide health information system. Health E-Way is also referred to, or it's a successor to the National Health Information Network, and that's a public-private partnership that operationally is supporting the eHealth exchange, or a community of exchange partners that share information under a common trust framework. So it's helping to develop the policies and the protocols and the specifications that the consensuses are necessary for secure and private exchange of health information. Just recently, the ONC issued a governance framework for trusted electronic information exchange. They did not regulate this because they see it as continuing to evolve. And their intent in issuing this framework was to provide the common foundation for all types of HIE and encourage the data sharing and participation. It has 4 principles, organizational principles, that are geared towards creating more transparent, consistent HIE access and use. Trust principles geared towards patient trust. And a lot of these systems will either have a patient opting in process where patients need to consent to have their information shared, or the ability to opt out. And we want to encourage the trust and ability to continue to grow HIE use among patients and providers. Business principles. business principles to encourage entry standards, to promote collaboration and exchange of information across providers. And finally, technical principles to support the other trust and business principles that I mentioned. And here you also see an emphasis on having a priority for using federal standards, or if there are not federal standards, consensus standards that are developed to try and create a uniform standard. So a few practical tips. And one thing that I would, as I already mentioned, I would encourage you to look into what is available in your state and what the state standards and requirements are. We've all mentioned, I think, interoperability and connectivity as a big issue. And so when you're looking at HIEs and how you might start connecting and meeting some of these meaningful use requirements, think about some of these elements. One, interoperability and connectivity, sustainability. And as you saw from that map, there's a proliferation of models here. They were meant to be self-sustaining, but what happens when the grant money dries up? Is the HIE that you're participating in going to be able to continue and have a viable economic model? Privacy and security and what's in place to satisfy HIPAA and high-tech requirements for the security of that PHI. The state laws, as I mentioned, privacy and security standards in your state may be more restrictive than the federal law. Is there a certification process that's in place for the HIEs? The patient consent, which I also mentioned, and governance. How is the HIE, how does it build consensus? How is security implemented and enforced? And what's the framework for encouraging collaboration and participation in the HIE? And finally, contractual considerations. When you join an HIE, you should expect to be asked to sign a participation agreement, which would be your contract with the HIE, and it will say what your obligations are, but also what are the obligations of the exchange, of the HIE. What are the structures that are in place? Are there indemnities or releases of what happens if there's a breach of information? And then also you should expect to see a business associate agreement under the recent January 2013 high-tech omnibus rules. Entities providing data transmission services for covered entities and that require routine access to such information are now business associates of covered entities. And so this is something that you should also expect to see. And with that, I will turn this over to my colleague, Jim.
Hey, Adria, thank you very much. And would you mind keeping control of the slides, because I just had a technology issue here.
There you go.
Thanks. And I know new going into this, when you bring up the rear of one of these presentations, there's not much time. And I thank you all for your patience in staying with us. So I'm going to go pretty quickly through just a couple of things I wanted to bring up. I wanted to identify some things that may not be top of mind that I think could actually save you dollars and protect your systems. So just kind of think about them. And one is, ensuring that you have effective, meaningful use warranties, or at least, a discussion with your vendors that they are going to kind of maintain the products you bought so that they remain in compliance with meaningful use requirements. And I'll talk a little bit more briefly about how you can do that, and if you already have an agreement, what you might do. I wanted to raise the issue of medical device and EHR convergence and hopefully steer you on a path that will avoid making investments where you're spending money in one area only to find out that it doesn't work with either your EHR or your EHR doesn't work with your devices. And then finally, an increased importance and attention that I think all healthcare organizations should have with regard to their technology on third-party software impacts on their core systems, as well as on the terms that they sign up to on those products. So real briefly, on the meaningful use warranty on the next slide, I just gave you something to take a look at. We're not going to read it here, of course, but there really are, there's going to be ongoing needs to adapt as new standards and requirements come down. And you heard Ralph talk about meaning use 4 and 5 potentially. and you just need to stay on path. And the issue is that something that you want to get hit for an upgrade on every time that happens, or is there some compromise that should come as just a revision to the product? Because if you bought the product as a functioning EHR, it should stay an EHR. There are a lot of different views on that. I'm sure the vendors would have a very different view than I might have, and that the CIO of a healthcare organization might have. But you need to attend to this, and even if it's too late to have a warranty because you've already signed the deal, this is just something that you should put on your calendars to be tracking and to ensure what the development path and what the approach your vendor is using to ensure ongoing meaningful use compliance. The second area is this convergence between medical devices and EHRs. And the reason I bring it up is because both are areas of significant investments, and traditionally they've been owned in different areas of many healthcare organizations. The clinical folks had the medical devices, and IT had EHR, and they're off making their own decisions on what to do. And the reality is that as is happening now and increasingly will happen in the next few years, medical devices will become one of the most important input elements of your EHR, provide some of the best real-time data and most complete data to those systems. And it makes no sense to either buy an EHR that's not going to work with medical devices that you're heavily invested in, or vice versa, to be reinvesting in medical devices that will not work well or integrate well with your EHR. So this is something that's kind of hasn't gotten a lot of attention. And if you go to the next slide on, Adria, I'm just recommending that you take a look at a few items. One would be, make sure that your agreements going forward with the EHR vendors have protection that they will integrate with the medical devices, and that should be a part of your procurement RFPs for devices and or EHR software. Think about the confidentiality issues. One of the big issues is that the equipment is easier to hack than systems are typically, but when you're on an integrated platform, which many of the devices now will operate on, both the software and the devices can operate on a single platform, there could be increased exposure to confidentiality issues. Make sure that you have license rights to use the devices with your EHR, and make sure that you understand the requirements of both your EHR and the capabilities of devices that you're going forward with, so that you can make these work together. And that's just a discussion to have internally, but it would be a real shame to invest millions of dollars in devices that would not work with your EHR or work as well as they should. The final thing is, increasingly, for years people would buy EHRs and systems, and there would be some third-party software that was provided, and often these were attachments to an agreement that nobody paid too much attention to, because this was often software that operated in the background, whether operating systems or databases, that were important to the functioning of the software, but that if the software was going to work, those third-party systems would have to work. So there was a kind of built-in incentive that the provider would be on the hook, because they wouldn't be able to provide you a functioning system if that third-party software failed. Well, increasingly, as we move toward significant third-party decision support and content packages, voice recognition add-ons, kind of different third-party products that are often presented as standalone products, I think it's important that CIOs and healthcare organizations think about, how do I ensure that the development paths of these important products are linked, and that after I get my folks, for instance, trained on voice recognition or using a particular decision support system, those products aren't going to diverge in such a great way from my EHR that I'm going to have to redo that effort. And what does that mean? So some thought up front in terms of thinking about the products you're buying and getting some protections there. And if it's too late to have the thought up front, discussions with your EHR vendor on key third-party systems and software is appropriate. So that was all I wanted to get through. And I'll turn it back over to Rick.
Thank you, Jim. We've got a few minutes left here for Q&A, but before we answer a couple of questions, I wanted to read the code for our New York, New Jersey, and Kansas attendees. And that code is Z as in zebra, F as in Frank, E as in Edward, and B as in boy. So I think that's what you need to get for CLE credit in your states. So we had a couple of questions come in during the presentation, both related to the meaningful use portion of the presentation. Ralph, so I'm going to direct them to you. The first has to do with the year that you were referring to in the meaningful use program, whether that was the federal fiscal year or a calendar fiscal year, and so was hoping that you could address that.
Yes, that's a good question. Actually, the participation years are different for hospitals than they are for providers. So hospitals follow the fiscal year, as opposed to providers, the participation follows the calendar year. So that's basically it.
Okay, thank you. Another question was, can you address the privacy and security requirements of meaningful use, particularly in light of the stage 2 emphasis on data exchange?
So the requirement for providers is the privacy and security requirement for providers is to address the HIPAA risk analysis. It's actually, it says to conduct or review a security risk analysis in accordance with the requirements of HIPAA. And what's new in stage 2 is CMS has added, including addressing the encryption and security of data at rest. So that's new for stage 2. It wasn't there for stage 1. And of course, implement security updates as necessary and correct, identify security deficiencies as part of the risk management process. And I think this is that's where I think a lot of providers sort of are caught off guard because it's not just filling out some template for a risk assessment. It's actually having having the internal process in place to analyze what the results of that analysis is, and then subsequently address the deficiencies. So if you take a look at that requirement, you can split it into 3 parts. The risk analysis. Now remember, the risk analysis is a HIPAA requirement. So it's been here for a long time. It's not new because of meaningful use. It's actually a requirement that's been in place for quite some time. So in theory, that's why the measurement says conduct or review, because in theory the providers and hospitals have been doing this all along. So you can just simply attest to having reviewed the risk analysis. So ask yourself questions such as, have you identified where the electronic PHI resides within the organization? And this includes ePHI that you create, that you receive, maintain, or transmit. So in other words, I always say, put your electronic house in order. You have to know where the data is. Kind of like what you would do when you're preparing for legal holds. You want to know who where your data resides. You want to know who your custodians are. Well, that's sort of what you want to take a look at. But in addition to just your regular risk assessment, looking at where the data is, you also have to address the encryption of the data. And the data at rest really is aimed at what are you doing about the data that's stored in the certified EHR. So CMS has reported that about 40% of large breaches involve lost or stolen devices. So everybody's heard the stories in the media about, servers gone missing, laptops that get stolen out of people's cars, etc. So had these devices been encrypted, then the data would have been secured. So the addition of this data at rest into the stage 2 requirement, I think, really is trying to address not to add anything. It doesn't add anything to the HIPAA requirements. That you're still, providers are still following the HIPAA requirements for risk assessments, and the only thing is that you now have to really put an emphasis on what are you doing to encrypt and secure the data at rest. And last but not least, like I mentioned before, the fees that everybody, and I always, I mention providers because solo and small providers, small practices are often the ones that have less resources available, and so they tend to skim on some of these issues, whereas hospitals and large health delivery systems have an infrastructure that's conducive to doing a lot of these risk assessments on a routine basis and taking care of policies and procedures. So with that in mind, it's the implementation of security updates are always looked at in relation to the size and the resources that the provider has. And so there has to be a determination of the appropriate manner in which these security, the deficiencies are going to be addressed. So, and last but not least, I know we've gone a little bit over time, but it's not a requirement enumerated in stage 2, but I think it's sort of a requirement it's subsumed within the entire program that you must be transparent to patients. So educate them about how the hospital or the practice is addressing privacy and security issues. Provide them with an assurance that their information is secure. Adria talked about HIEs, and there's this concept of moving from just a privacy notice to how am I going to use the data that I'm going to exchange, and you have to be transparent, open and transparent about how the data is used or not used. So that's it.
Great, thank you so much, Ralph. Well, that takes us to the top of the hour, and so we're out of time at this point. I did see a few other questions come in, which we'll try to respond to after the call. So I just wanted to thank you again for attending, and I'd like to thank all our speakers again, and I hope you enjoyed the presentation, and the materials are available on the website. Thank you very much.